Hello? Hello?
Hi there, this is Rachel.
Hi, Rachel.
How are you doing?
Oh, doing all right. How are you?
Not too bad. Thanks for joining us this morning.
Yeah, I think as far as I know, this is like a repeat of the earlier version. I think Jen wanted to have two opportunities for people. So do we have any idea how many people are planning to attend?
We don't, one of our clinics had to cancel just this morning. They're having some server issues. I'm not quite sure. I think we had one or two that were planning on attending. So I think we can just keep an eye on folks joining in as we get closer to 11.
Okay. And I think I remember at some point I get the shared screen um, option.
Yes,
I
absolutely.
think I have everything I need here.
Perfect. Sounds great. And we are recording the training, recording now. So Dr. McGovern developed the IMAT and has been working with practices across the country in implementing the IMAT as an assessment and development tool. So I think that he's got some really wonderful insights into what primary care clinics have as opportunities to I think, grow their practice around some of these issues that we're talking about as a part of the IRIPS consortium. So we are very, very thankful to have him as a consultant on this project and working with our clinics across the state of Idaho. So thank you again for joining us, Dr. McGovern. I'll turn to some of our clinic participants just to give you a quick sense of who's on the line. Anthony, could you start for us?
Yeah, my name is Anthony Peterson. I'm a clinical pharmacist for Mariman Health. We're in Plummer, Idaho, about half an hour south of Coeur d'Alene, Idaho. We are a FQHC plus a tribally run clinic, so we pretty much see everybody. Usually it's lower income patients, but we do have a clinical pharmacy program. We are dabbling in MAT. We're trying to expand the program right now, but we're still pretty new to it. But yep.
Hi, Anthony.
Hi.
Thanks so much, Anthony. Steph?
Yeah, hi, my name is Stephanie, and I'm a behavioral health consultant at All Seasons Family Care Clinic. We are a reverse integrated clinic, meaning we have mental health services offered and we are incorporating primary care into our practice. And so we are also a part of that IROPS grant as well.
Hi, Stephanie.
Perfect. Thanks so much. And then Dr. Lima?
Hi, I'm Dr. Ann Lima. I work as a family physician in Orofino, Idaho at Clearwater Valley Hospital and Clinics, and I'm a buprenorphine waivered provider, and we have two others in our clinic and are kind of in prelim discussions with our counseling services to do a more focused MAT program in our community.
Hi, Dr. Lima.
Well, thanks again for everyone for joining. And with that, I'll turn it over to Dr. McGovern. And please feel free to ask questions. Again, just noting that we do have the recording. So if you have colleagues that you think would benefit, just know we'll be sharing that back out. And you'll also have a chance to have this as a reference going forward as well. So I'll go ahead and turn it over to Dr. McGovern.
Thanks, Rachel. Good morning, everyone. Is it still morning in Idaho?
Yeah,
Yes,
it is here.
All right, good. It's definitely the morning in the Pacific time zone. I'm Mark McGovern, as Rachel said. I'm based at Stanford University School of Medicine and Stanford Healthcare, and in the Department of Psychiatry and in the Department of Medicine, and have, because of my background in addiction treatment and addiction medication services, have gotten very involved in the state of California's effort to deal with the opioid epidemic. And I'm not going to tell you too much of the the background because it's actually part of the presentation. So I want to make sure I don't sort of get to the punchline too prematurely. But I'm really excited to be working with Jen and the iRopes group around this project. I think you're clearly early adopters or innovators. I get the feeling that people are, as Anthony said, kind of figuring out how to get it started. And I know at Clearwater there are a few X-waiver providers, but I think I got the feeling from Christine that there's a sense of wanting to develop a program that's more of a team-based program, perhaps. And then I think at All Seasons, Stephanie, you're still building yourself. So I can tell you a lot as we go about just some of the anecdotes working with other FQHCs and community health centers and primary care practices. I always feel like I need to apologize because I'm based at an academic medical center. Zero of the work I do outside from clinical work is at the academic medical center. Everything I do, which is the bulk of what I do, is in community public health and public mental health type organizations. So I can totally identify where you're coming from, and that's been my background too. So I'll jump right in. I think I can navigate. I'm going to try to share my screen, which might actually be an adventure. So bear with me.
Dr. McGovern, while you're doing that, it looks like we've had someone join us via phone, number ending 7510. Did someone join us?
Yes, this is Ann Daggett from the CHU organization.
Hi, Ann. Thanks for hopping on.
Thanks.
All right. Can you see my screen?
You can.
Please don't judge me by how messed up my desktop is with folders. I plan on getting to that tomorrow. Okay. All right, so hopefully you're oriented. This is the date, the 16th of December. Here's my plan, and I think, we set aside 2 hours. This is actually something that we did about a month ago, and I think we were able to get through it a little quicker than 2 hours. So, if you have to jump off and come back on, you can do that. If you have to jump off, I think the key points, hopefully, that I need to make will be, within 45 minutes to an hour, and then the rest of the time we can certainly use for questions. But, I think I hope to cover these areas, just sort of introduce a little bit about the kind of work I've been doing, which I think is relevant to the kind of work that you're doing or thinking about doing. Just sort of review what we know about the opioid epidemic in America and the data that I've been able to pull together. Actually, Ann was really helpful sharing data that has been gathered in Idaho. The three-pronged solution, I'll explain what that is, and then talk a little bit about MAT. We call it medications for addiction treatment, and MAT for short. And then I'll give you a little bit of the origins and the rationale behind this this organizational capability measure that we call the IMAT-PC, and then we'll try to walk through it. I think we have received or you've submitted some of the data from your IMAT-PC already. I don't think every clinic has submitted the IMAT-PC. There may be one or two that still need to do that, but I hopefully after I talk about it a little bit, you'll be encouraged to do it, because I think it's ultimately going to be very helpful. So I was talking with Rachel before you joined. I'm from Vermont. I'm a Vermonter, and this is kind of a classic scene. Probably not right now. Those leaves are fully on the ground, and there's a lot of white stuff on the ground and on the trees. But this is a shot of October around Columbus Day in Vermont, and that's what a lot of people think of when I say I'm from Vermont. Actually, nowadays people think of Bernie Sanders when I say I'm from Vermont. It's a slight shift in what is the icon for the state, but a lot of people don't know where Vermont is, and in my time in California, I've realized that when I say I'm from Vermont, people aren't really sure that that could be where Idaho is. It could be where Mississippi is. It could be out there near, New England or where Virginia is. So there's a lot of misunderstanding about where it is. So you can see that little dark green area. It's actually the Green Mountain State. So you can see where it is there. The other thing that is really important, and this is kind of what I got absorbed into about 10 years ago, was the kind of the early signal for the opioid epidemic in northern New England. And this was literally on the cover of the Rolling Stone magazine, and really is a sort of a caricature of the Vermont iconic maple syrup tin. Obviously, conceptualized as a lumberjack about to bang some heroin into his arm, and that really was the kind of the state of things. And you couldn't go very far without knowing someone, or knowing someone who knew someone who had died from an overdose. It was one of the first and most significant states in terms of opioid overdose. There was a great kind of unprecedented effort on the part of the governor himself, Peter Shumlin, who acknowledged that it was a public health crisis and kind of went on record declaring it as such, but more than rhetoric, was able to increase financing and got a lot of kind of support from people across the state to share resources and to, accept changes in tax structure. It was a Medicaid expansion state, so a lot of the focus on the Medicaid 1115 was towards developing capacity to address the opioid issue. So one of the things that came out was the beginnings of the three-pronged solution, which you can kindly see here. It included increased access to overdose rescue, changes in opioid prescribing, and then development of this hub and spoke model, which it turns out has been widely adopted across the U.S. And I think this is part of the model that's being envisioned for potentially being of use in Idaho. So the hubs would be specialty opioid treatment programs. We call them OTPs. OTPs are heavily regulated by the DEA and FDA to dispense methadone, and you can, as another kind of provider, you can use methadone to manage pain, but you can't use it to manage addiction. So the OTPs are specifically designed to dispense methadone under very highly regulated conditions and rules. Buprenorphine and naltrexone are two relatively newly approved FDA-approved medications for the treatment of addiction, specifically opioid addiction, although naltrexone is FDA approved for the treatment of alcohol use disorders. But the hubs would be, by virtue of being able to prescribe methadone, are seen as specialty care kind of clinics that can offer all three of the available medications. And spokes are office-based opioid treatment programs, sometimes called OBOTs, so OTPs and OBOTs, to really categorize a family practice, a emergency department even, or a primary care clinic, an FQHC, that is licensed and capable of prescribing buprenorphine and naltrexone, not methadone. The other thing that happened in Vermont, and I alluded to this, was the insurance coverage for both the medication and the services, so pharmacy services, physician services, and last but not least, behavioral health services. So there was a great deal of investment and resources. Many of the spokes that saw a large number of patients were actually able to apply and get additional clinical staff. For every 100 patients they were treating, they were able to get one FTE nurse and one FTE behavioral health clinician. If they had 50 patients, they would get half of a nurse and half of a behavioral health clinician kind of added to their practice if they wanted. There were a lot of efforts to improve the quantity in terms of the number of patients on the medication, the number of X-waiver prescribers, and there were also a lot of efforts to ensure the quality. There's been a great deal of effort, as you know, or perhaps you know, around expanding access and increasing capacity, and a little less focused on the quality. So, which could be a concern, actually. Okay. So, some part of my work is what's called implementation science, which is a relatively new science, and I'm happy to talk on and on about that if given permission, but I'm not going to burden you guys with that today. But one of the aspects of implementation science is really thinking about implementation outcomes. And one part of outcome we always think about is do patients get better? And that's certainly a part of an implementation outcome. But the other implementation outcomes have a lot to do with these kind of things here. And if you don't learn anything today, maybe you'll at least learn the meaning of one implementation outcome acronym called RE-AIM. It's a RE-AIM framework, and it consists of REACH, which is the number of patients who get a treatment over all those who need it. E stands for effectiveness, which is probably closer to what we normally think of as effectiveness in terms of, symptom change or reduction in mortality, morbidity, et cetera. Adoption, which has to do with the number of people who are delivering a treatment over all those who are in position to deliver it. Implementation is really about kind of the quality of care. Is it being delivered according to guidelines? Is it being delivered as designed or with fidelity according to standards? And then M has to do with, is it being maintained? So the Vermont approach, basically, as you can see, was pretty successful. There was a huge increase of the number of patients getting addiction medications from 800 to 8,000, so that's a huge jump. Unlike the other New England states, which are neighboring states like New Hampshire and Maine, Connecticut, Rhode Island, that the overdose curves never bent and continue to rise, largely driven by fentanyl. Still, Vermont's overdose death rate stabilized and decreased. There was an increase in the number of those OTPs I referenced from 3 to 7, so doubling patient family access to those, and the number of OBOTs, or community health centers, family practices, and so on, went from less than 100 to, I think it's closer to 300 now. We used a learning collaborative strategy to improve adherence to the guidelines. And I think I can talk a little bit more about that and how you guys are kind of in the basis of forming that kind of learning collaborative. And the good news is that this hub and spoke model in Vermont is now in its 7th year, and I'm still involved. I used to, like I said, I used to live there, but I moved to California a little bit ago. So it's not perfect, but some of those outcomes are actually really really impressive as these things go. So I said goodbye to Vermont in January 2017. Those of you might know this movie, John Candy, Steve Martin, Planes, Trains, and Automobiles. If you haven't seen it, it's not a classic Christmas movie, but it's got some winter in it, so maybe it could become a classic Christmas movie. So here I arrive in California a few days later, and this was not what I had in mind. This was Donner's Pass. So you guys in Idaho probably can identify with something that looks like this. It's not what I came to California for. I can tell you that. But this is what I got. Welcome to California. No palm trees and Beach Boys. This was a lot more like Vermont. So we tried. I got asked to help the state of Vermont's effort to deal with the opioid epidemic. I was really not expecting to be doing as much of that kind of work, but when I arrived, a colleague said, well, we have a big issue with the opioid overdose here, particularly in northern counties, not necessarily in San Mateo or Santa Clara County where I'm based and where I live, but northern counties like Plumas County and Mendocino County and Humboldt County, that places that probably resemble a lot more of the places where you live and work, that are more rural. They are inclined to be a little less diverse racially and ethnically, although there are Native American Indian tribes and a lot of Caucasian folks living in those parts of the state of California. So adapting the hub and spoke model in California, which is a very different state. Obviously, the county of San Mateo probably has twice as many people as the entire state of Vermont. So you're just thinking in terms of the population alone, let alone the geographic, size and kind of diversity and dispersion. Well, a lot of questions were, could it be adapted? Could it work on the West Coast in a very large and diverse state? So about the same time, and this is probably what led to my getting involved, former President Obama signed into law an act called the 21st Century Cures Act, which really led to an unprecedented amount of money being targeting the opioid epidemic across the 57 US states and territories, billions of dollars actually. And I think there was a lot of concern in the change of administration that maybe the new administration would not want to see these funds go out and try to kind of corral them and redirect them. But the Trump administration valued the effort to solve or address the opioid epidemic and really did nothing but increase the funds over the past few years. So it's been really interesting. It's kind of a bipartisan issue whenever things come up to support efforts to deal with the opioid epidemic. It's one place where both sides of the aisle agree that this is a major concern for the country. So the idea is that we were going to adapt the hub and spoke model for California and, kind of redesign it and do a lot of the same things that we had shown that we could do in Vermont. And I didn't show you a map of Vermont. I'm showing you a map of California to indicate that we have about 18 hubs. Actually, this shows 7. You can't quite see it, but there are 18 hubs with a whole bunch of spokes. And this is where it was in 2017, with hub locations in kind of orange and the spoke locations in blue. And you can see that the number of orange dots didn't change much, but the number of blue dots changed significantly. So these are places that, like we're just on the sort of the precipice or the threshold of getting started. Many of these organizations had 0 X-waivered prescribers. Some of them had 1 or 2 or 3 or 4 X-waivered prescribers, but no patients. Some of them had a couple of X-waivered prescribers and 1 or 2 patients. So it was really, as you can see, and I believe this number of spoke locations is now over 200. So a pretty significant increase in the number of people who sort of jumped in the game. So I just wanted to take a step back, and I don't know that I need to show these slides other than, the punchline is there's an epidemic, and we need to respond. We need to do a better job of responding. So the overdose death rate, continues to be pretty high. Unfortunately, overdose death is something that we look at in the rearview mirror. I'm working with colleagues from Northwestern and Chicago and University of Miami to develop models to anticipate where overdose deaths are going to take place, kind of using agent-based modeling to predict areas where there might be an outbreak of overdose death. It's typically not public health data. It's more data from arrest records and social media, which is really kind of interesting. But as of 2017, the overdose death rates continued to grow. We think these are conservative estimates because they rely on the coroner or the medical examiner to record the death as a drug overdose. And we know in many places, such as Pennsylvania, for example, there's often a reluctance to do that. And keep in mind, and this is, someone pointed this out to me, that there's still more people that die every year from tobacco-related disease, and even secondly from alcohol-related disease than from opioid overdose. But I think what's different, well, there's a bunch of things that are different. One is probably the dramatic and kind of unexpected sudden nature of the overdose death, which makes it seem more preventable than a kind of a chronic condition, which is more insidious. And, there's a heck of a lot of disease progression before death with alcohol and tobacco. So, this is really just the graph of the increase, and you can see there's the synthetic opioids, such as oxycodone and hydrocodone, and then you can see the rise of fentanyl. Fentanyl is, kind of a anesthesiology grade, operating room opioid, high potency, being manufactured in China and then funneled through distribution lines, mostly through the cartel in Colombia and extending into Mexico, into all parts of the U.S. and through Canada. Often, kind of cut into supplies of heroin, which increases the potency of the heroin, and sometimes, obviously can often lead to overdose death. Some data that suggests that originally it was assumed that people did not know that their supply of heroin included fentanyl, that it was kind of a surprise to them, but 99% of people who use heroin know if it has fentanyl, in fact, have paid probably a little bit more for it. And if people die of overdose with a certain batch of fentanyl in the heroin supply, it's often seen as good stuff. So if anything, that kind of gives you some indication of the severity of the addiction, the attachment to the substance, even though death is a potential outcome. So I think what's really interesting is that these rates have stabilized just a little. So the slope is not quite as steep as it was. One thing I do want to point out, and I don't know if you've seen this clinically or epidemiologically in Idaho, we've certainly seen it in California, and I mentioned projects in Florida and New England, and we definitely see increases in methamphetamine. And it's not the methamphetamine that was, being manufactured in sort of rural homes and trailers, and this is much high quality, again, manufactured in labs, and the quality is excellent, potency is great, and at least at the moment the cost is low. And the same is true with cocaine. There's increased seizures of cocaine, again, high quality, lower cost, and we've seen increases in people seeking treatment, and I can tell you it's one of the major concerns of people who are treating people with opioid use disorder in California. Some are calling it the twin epidemics, opioid and stimulants. Stimulants would include cocaine and methamphetamine, and others are calling it the fourth wave. The first wave was prescription narcotics. The second wave was heroin. The third wave was heroin cut with fentanyl, and the fourth wave would be stimulants. So just something to keep an eye on. And you can see here with the data that cocaine and methamphetamine, started out pretty low, but there's a gradual increase. And I think to the extent that we get these kind of data, through our rear view window, we notice that these rates are continuing to climb. Overdose mortality, this is with opioids and without opioids, and you can see with opioids, there's a slightly better or higher rates of overdose death. And same with methamphetamines. That first one was cocaine. So here's the information that we have on deaths related to opioids in Idaho. And I haven't been able to get anything newer than 2016. And I don't know my Idaho geography particularly well. I don't know where All Seasons, Clearwater, or St. Mary's is relative to, county maps. So if you're in Clark County or Butte or Bear Lake, that's probably, those are higher death rates than, some of these bluer counties. But Boise and Valley, would be in the higher zones, Bannock and Power. So could anybody, do you guys want to share, like, Stephanie, where is, where's All Seasons and what county?
We're in Ada County, more toward, I would say, like the bottom over by, looks like Elmore or Boise.
Got it right here.
Hmm.
Okay. Anthony, where's your clinic?
We're actually in Benoit. It's up in the North Idaho Panhandle.
So that would be considered a higher rate of overdose. Dr. Lima, where's your clinic?
We're in Clearwater County, just south of Shoshone there, in the northern part.
Got it. So you guys are all in rural areas, huh? So it's happening, and I don't know relative to 2016 if there's been increases or decreases, but I'm sure you read about it and you hear about it and you see people that are affected. And here's just another way of looking at it. I think it looks like Ada is one of the heaviest impacted, using it this way. Clearwater, but Ada looks like it's a good place to be doing an intervention like this. This is another, these are specialty care admissions across your specialty care addiction treatment programs. You can see there's an increase in rates of admission. I think these are still kind of low. I mean, it's 15%, 16 to 15%. Usually number one is alcohol. My guess is that these rates probably are a lot different now. And then for heroin as total admissions. So I think it shows an increase, and my guess is it's a conservative increase. I have to move the camera around so I can see this slide, but you can see that, people getting buprenorphine, I think the opportunity to expand buprenorphine practice is pretty significant in Idaho. This is a public service announcement that we spotted when I was there. So it's interesting. A lot of the states and territories that got the Cures Act money, I know in California, is about $50 million a year times 4 years. So, that's a pretty significant chunk of money, regardless of where you come from. I don't really know what Idaho's share was, and I know less about what Idaho's been doing with it, but I think the opportunity to change the public perception about interest in seeking treatment, maybe spread the word about drug and alcohol problems, and you can see secure meds and dispose of meds. So I think that Idaho is trying to do a good job, and I think this grant is a big part of it. So the emphasis are really, changing guidelines for prescribers. I don't know much about what's happening there around along these lines. I know there's a lot happening in California. I'm part of a group at Stanford, trying to adjust policy around prescribing, identify patients who are on high doses, of 90 or more morphine equivalents. And I think a lot happening on the use of the overdose reversal medication, naloxone or Narcan. I think that's been Idaho's major strategy, is to get Narcan out in pharmacies and in the hands of first responders and police and family members to provide rescue for overdose. But we know that that's really kind of it's not really treatment, it's really life-saving. So that makes it a treatment, of course, but it's really rescue. The treatment really comes in the access to these FDA-approved medications for opioid use disorder. And again, a lot of us call it MAT, medications for addiction treatment. So I won't spend a lot of time on this, pharmacology, but methadone, as I mentioned earlier, dispensed under highly regulated rules. You have OTPs in Idaho. I don't remember how many there are, but there are a few, mostly in the urban area. I don't know that there's one in the north, but maybe you can tell me that there is. But it's often a challenge for people to get methadone because the requirements for dosing often involve daily dosing under highly observed conditions. So patients typically don't prefer methadone for that reason because of the structure, but some patients actually need that type of structure in order to get the medication. And the outcomes for methadone via Cochrane reviews and meta-analyses are slam dunk, highly effective in reducing opioid use disorders and improving the quality of life and reducing crime, which is a big thing, as you know, for some patients who suffer from these kind of addictions. Just as a metaphor, we say, it's a full agonist. So the more you get, the more of an impact it's going to have. More is more. Buprenorphine is a partial agonist, and again, you need the X waiver. So Dr. Lima is an example of someone who said, I'm going to do this. I think I want to do it, and goes through the training to get the X waiver. It's interesting. Some people would say ironic that you don't need to do this for other medications, which are potentially far more dangerous. But I think the feeling is that we do want people to kind of know what they're doing, less about the technical aspects of prescribing, which are in many ways not all that complicated, but really the people for whom you will be treating, the people who suffer addiction. So buprenorphine, I don't know if you've ever had an experience with this, but you can only use so much, or you can only get so far, or in this case, go so fast with buprenorphine. There's sort of a limit on how impacted or how affected you get as you increase the dose. Now, Naltrexone's an antagonist, so it really binds to the receptor, so it blocks the effect of the opioid. We call it like putting gum in a lock, or if you happen to be on the East Coast, this is how people will save their parking places so that somebody doesn't come along and park in a spot that they've cleared out. And the snow's already melting here, so probably not big of a deal. But when the snow's 4 and 5 feet high and you have your little place carved out, being able to block it is a pretty standard practice. And what else are you going to do with your patio furniture in the winter anyway? So that's good use of it. So this is a really interesting, and this is 2015 data. I wish I had a more current thing to show you like this. I know some people that are working on this in public, the public sector, and also in VA, trying to redo or update this map. Unfortunately, Christopher Jones, who was at the Substance Abuse and Mental Health Services Administration, was the one that put this together. He now is with the CDC and is working on other diseases. So we lost really a great resource to do this kind of work, but hopefully someone else will pick up the ball. But in a nutshell, the more, the darker the shade of blue, the higher the rates of addiction to opioids. These are data that are based on household surveys. So you could just imagine, people responding to household surveys saying that they use illicit drugs, and even though they're reassured that their information is, confidential, I still can't imagine anyone saying yes to any of those questions. So people do, and that's where these estimates come from. But that they're probably underestimates and maybe tips of the iceberg to the actual prevalence rates. But still, when it comes to this stuff, these are the best estimates that we have from an epidemiological perspective. The gold dots have to do with treatment capacity. So the bigger the dot, the more treatment capacity. So what you would like to see is, for a dark blue, you'd like to see a big yellow circle, and maybe for a lighter blue, it's okay to have a smaller circle. And you can see some of the states that are in blue with higher rates of dependence still have some small circles, and you can see where they are. And here's where you are, which is kind of a mid-sized state in terms of self-reported opioid use disorder, and a relatively small, small dot, which indicates the opportunity for improved access is right there. And here's Vermont, right, high rate, and then bigger dot. Again, based on some older data, and I think in some states this might be old information, especially as billions of dollars have been devoted to trying to deal with it. There's another way of looking at the data. So kind of above the line is considered, kind of better, meeting need and capacity. Below the line is probably not doing as good a job in terms of, meeting the need or capacity. I think I remember Idaho is down here somewhere there. So yeah, I think there's a great opportunity in Idaho. Again, we haven't seen any current data out of your state or nationally that would sort of parallel this or update this. I hope that people are going to be able to develop that based on all this funding. So, what's the problem? I guess what's the problem with access? And so, I'm working in California right now with the project involving 62 federally qualified health centers from San Diego to, the far northern border with Oregon. And these things kind of hold true based on survey and qualitative data. So in general medical settings, there's often a question about not so much the medications per se, but the people who have addiction. Are those our people? Should we be treating them? Are we trained to treat them? Are they really suffering from a disease, or should they be treated within the context of correctional programs or social service agencies? They're not really a medical condition. It's really kind of a matter of choice, and probably a poor choice, and maybe even a poor character. So there's still a fair amount of stigma associated with people who suffer addiction. So the fact that you guys are on this call, the fact that you guys are jumping into this, and there are some generational differences. Newer generation versus the older generation sort of sees addiction and even mental health issues a little bit more, a little differently, let's say. There's also a lot of doubt that the treatments work, because many people in training have been exposed to the most severe cases of addiction, and have confronted people who don't acknowledge they have addiction, who deny or minimize, who refuse treatment. So there's almost a sense of treatments don't work, these people are hopeless, and please send them to someone else, not to me. And the lack of perceived expertise, like I was never exposed to this in medical school or graduate school or residency, unless I had a kind of a VA rotation perhaps. I never had really good mentoring. Maybe I had negative mentoring. Of course, these other things come into play, lack of time. If I did this kind of work, I couldn't do it within the context of a 20-minute visit or even a 30-minute visit, that these patients would be really demanding. And what if I did need social work help, or what if I did need to get a group for people? Could we actually do that? No, probably not. So there's a resource issue. In some places, there's also a sense that we're not going to get paid to do all the work that's involved, that's needed for these patients who are really complicated. So, we get hammered on the time and the resource issue. And then there's the workflow, like who's going to do all of this urine drug screen work, and who's going to do the care coordination if these people are involved in child welfare or criminal justice with probation and parole. I don't really have time for all that, and we don't really have the staff that can manage all those kind of relationships or even in clinic processes. And that relates to workforce. So Stephanie, you mentioned that you kind of a reverse integration. So the idea is that maybe we have behavioral health clinicians, but maybe our behavioral health clinicians don't know a whole lot about addiction. or maybe we have licensed alcohol and drug counselors, but they don't believe in medication to treat addiction. They believe in 12-step recovery models or abstinence-based models. So the workforce issue turns out to be really significant, and I can talk more about that in a bit. And then what if I do take these kind of patients on? Who do I call when things get a little gnarly, right? How do I interpret a urine drug screen? How do I deal with a patient who is also using benzos? Or how do I deal with the patient who's drinking? How do I deal with the patient? And so on and so on and so on. So being able to have that kind of person at times to hold your hand, but also at times to just be there if you run into a question, turns out to be really, really significant. And like with any practice, sometimes it's early on that you really appreciate having that kind of backup around, whether you decide to use it or not. And one of the things that's really interesting, and you might appreciate the irony, maybe not, but we have a long history of specialty addiction treatment in the country. And, you know about, rehabs and residential programs, and, about detoxes, and, about outpatient programs, and, fairly significant culture and traditions around those programs. And although, people in those programs are used to dealing with folks who suffer addiction, but it's a newer thought, the newer practice to use medications to treat addiction. And there's a lot of beliefs, myths, if you will, about the use of medication to treat addiction. So I put here that you accept the people in those programs, but you don't really accept the treatment. So there's a sense that a drug is a drug is a drug, and not making a sense that a medication is a little different than a drug. Maybe a lack of appreciation of the neurobiology of addiction and how it works, and how just as will is not effective to combat the attachment to a substance, will may not be effective to comply with treatment. The other issue is that some of these specialty care programs haven't been really well funded, and haven't been able to afford professional staff. So having access to a prescriber, either as a consultant or a paid employee, per diem, or even a medical director, turns out to be pretty rare. And that, I think, relates to resources and funding. So really interesting time. And still, excuse me, some of the data on general medical settings, like where you work across the country, it looks like about 60% to 2/3 of FQHCs now offer addiction medication. So 2 out of 3, which is good, right? It could be better. And for specialty care settings like a traditional addiction treatment programs, you would think it would at least be 60%, but it turns out that it's about half that. It's about 30%. So your chances of getting an addiction medication are better from your primary care doctor than from going to, your garden variety specialty addiction treatment program, which I said is at least ironic and probably more preposterous than anything. And we're working on it, but it's still true. So what's the IMAT PC? One of the things that we were struck with, and particularly in doing learning collaboratives, is that there was a sense of, well, all we had to do was jump in and start prescribing. And, I think we sort of fast tracked over the whole idea of quality and guidelines. So the IMAT PC was really our attempt to think about, well, what are the current guidelines? How could we put them kind of in an order that made sense, that were sort of practical and user-friendly without being overwhelming? And that could be used to sort of, chart current state, like what are we currently doing? And then maybe even use the information to figure out where we wanted to go. So I think was really the thinking, together with a group of folks in California, Brian Hurley, who's a addiction psychiatrist at UCLA, and myself or mainly, and then a few people who've been involved in primary care practice implementations in San Diego and Los Angeles and here in the Bay Area, sort of collaborated to come up with various versions of the measure, and then had clinics around the state field test it and kind of give us feedback on it. So let's see, I have to reduce these pictures. So IMAT stands for Integrating Medications for Addiction Treatment in Primary Care. IMAT sounds good. It's 2 syllables. It's better than sort of stating out the whole thing. It's a benchmark measure. We like to think it's pretty clear. We believe it can help you assess your current state and then think about where you are and where you want to go. And I'll talk about that more in a bit. And then, at different points, we've struggled with how to complete it. And I think one thought was that you would host a visit from someone who was independent of your practice, and they would complete it, based on key informant interviews, based on kind of deep hanging out and looking around your clinic and talking with people who they met in the hallways and at the front desk and in the pods and offices and so forth. Maybe they would review medical records or anything you had that could track patients with opioid use disorder, and then fill the IMAT out based on a kind of an independent, neutral party. And that way you would get a kind of an unbiased, perspective on what you were up to on this addiction medication business. But we thought that probably would be too hard and too costly. So we basically built it to be used as a self-assessment measure, and it actually had experiences with other capability measures like this. And we tried it both ways, and we actually found that, the self-assessment approach is actually really helpful, but often yields a higher ratings or higher scores than the independent kind of third-party assessment. In fact, there's one project that looked at capability integrating addiction services in traditional mental health programs in Australia. Dr. Lee and colleagues, and they visited, they trained 14 of these clinic leaders in how to use this measure, and then asked them to do it. And then they independently visited these sites at the same time and served as kind of the third-party assessors. And on a 5-point scale, by and large, 13 out of the 14 sites were different in about 2 points, by 2 points. The self-assessment being a higher score than the independent assessment. And there's one site that had perfect agreement, which is interesting, but still, out of the 14, only one. So there's a sense that there's just a kind of a subtle self-report bias or positive response bias, however you want to call it, that we feel like we have to just sort of give people a heads up that you're going to have it. So we think that it's the kind of thing that's best to do, to sit down with everybody who, you think is a key player, a principal here, and complete it as a group, and realize that, if you're going to be using it as a measure of current state, it's going to be something that you want to re-administer later, and maybe think about, being conservative as you make the ratings, and then kind of give yourself room for improvement, if you will. So that's just a message. If you've already completed your measure, then you probably have a sense of that. So we have a few different versions of the things. There's a Word version, a PDF version, and then a kind of a workbook that's that's programmed to generate scores. We think, based on our experience with a bunch of different clinics across a bunch of different states, that it takes about an hour. We know that folks are sometimes inclined to say, okay, I'm going to complete it on behalf of the team because it's so hard to get the team together, and I don't really want to trouble our busy physicians or our busy medical director with this stuff. So I have a pretty good idea about what's happening, so I'll complete it on behalf of the team. And I totally get that, and I guess I think as long as you have data, it's better than no data. But it's probably better to have data based on the entire team's perception, where there could be some conversation, which actually in and of itself might be therapeutic. It might actually help you to identify things as a team where there's points of different perspective, which is really kind of interesting and something that you could learn from. So the IMAT has 7 different domains or dimensions. The first is infrastructure, which has a lot to do with the policy and the financing. The second one is really important, and it has to do with the culture and environment. And that sort of kind of contains what I talked about earlier around stigma, potentially discrimination towards the people, or even towards the treatment. So patient identification and initiating care is really how do you start the medication, under what circumstances, how quickly. So you can see that even though there are 7 different domains, the number of items in each domain kind of reflect the degree of importance of that domain. So obviously clinic culture is important, but we only could come up with 4 key benchmarks in that particular domain. So infrastructure, 5 items, but here you can see patient identification, initiating care, 14 items, because there's just a lot of different clinical considerations there that we thought we needed to capture. And then, delivering care and monitoring how people are doing, 10 items, care coordination, 6 items, and then workforce and staff training and development, between the 2 of them, 8 total items. So, we get to 47 items total. I don't know. I mean, it's possible that over time it'll be reduced. I hope not increased. 47 is a lot of items. Some of our other capability measures, we've been able to get down to 35 or so. So there may be a way to reduce the number of items on this. So, how to use it? I think most of you have submitted things, so it's possible. And I'm going to share with you some of the data that came in. But it's possible that after you hear me talk that you'll want to redo it and resubmit it, which I think is fine. I think it's being used for self-awareness and for planning purposes. And I think after this presentation today, that the team's going to get together and think about what kind of planning can we do for the next stage of the project in terms of support to help people be able to feel confident in jumping into this practice. But how to use it now is really sit down with your team if you can do it. It goes from each benchmark goes from a 1 to a 5. So 1 is I put minimally integrated, but it's actually a mistake. It's actually NI, not integrated. I think I was trying to sort of be a little euphemistic here, but not integrated means that either you don't have it or it's just not there in such a way that you feel is present enough. 3 is partially integrated, which means it's there, but maybe inconsistently so. So it's maybe something that one doctor does, but another 2 or 3 doctors don't do it that way. So it's hard to call it a routine practice. And a 5 is that you're doing it and doing it fairly consistently. And it's a 5-point scale. So, we think 2 and 4 are useful kind of as hedge bets. When you get to a 3, maybe you're not quite fully a 3, but you're much different than a 1. So a 2 gives you that option, kind of an in-between score. 4 obviously would be if you're not quite a 5, but it looks like you're doing more than the little explanation of what a 3 anchor might be. So it kind of gives you the opportunity to, to hedge your bet and kind of give you room to get up to a 3 if you're at a 2, or if you want to be at a 5 and you're a 4, it kind of gives you some room to get up to a 5. So that's why those kind of interim, if you will, hedged bet 2s and 4s really come into play. Sometimes people will say, Mark, can we, we're not quite a 4, but we're better than a 3. Can I go with 3.5? And we always say, yeah, that would be then a 7-point scale or even a 9-point scale. And that would begin to get really, really complicated fast. So, and if it seems like it's a 3.5, a perfect 3.5, how about giving yourself a 3? So there's never enough, right? There's always going to be a way to, people are groupers and splitters. And I think I think it's not an exact science, so it's always good to go with the one that's closest. Basically, you'd be trying to do this on a PDF file, and then we have an Excel workbook, which I think was sent along to you. And the beauty of the Excel workbook is it does a lot of the calculations and plotting of the scores, which I think you'll find to be pretty useful. And if you do like kind of the visual I know that some of the clinics we've worked with have actually cut and pasted the plots onto documents and used them as far as staff presentations or presentations with leadership to make a case about, where they were and what they needed, and in some cases how good they were doing, kind of as a way to seek affirmation. In other cases, as a way of pointing out, hey, we're not really doing this all that well relative to guidelines. We might need to look at some additional resources here, to really point out more objectively what a need might be. So this is one of the data points I just wanted to show you from California. It's a project called Addiction Treatment Starts Here. It's a first wave of FQHCs from the north and the south using the IMAD, and below here you have the different dimensions, and on this axis, the y-axis, you have the scores from not integrated to partially integrated to fully integrated, and you can see the error bars are the variation, and then the plot, the dots with the lines, line graph, are the averages. So of the 42 clinics, the average on infrastructure was 4.1 or 4.01 with wide variation. And I can tell you that out of these 42 clinics, some of the clinics had hundreds of patients, and we're already doing a lot of MAT, and we're really interested in scaling up MAT in their organization. So it might be that, of this one organization that comes to mind, they're based in 3 different counties. And it might be in one county, which is kind of closer to an urban area, closer to an academic program. They can get family medicine residents. They can actually do a lot of MAT, specifically buprenorphine. That particular county's sites, those clinics, are doing a lot of it. But they're really interested in expanding the practice to these more rural sites, the ones that are further out, right? The ones that don't have as much activity, the ones where, every patient in that community knows one another, and even the patients know each other. They know all the staff that work at the clinic. So there's a lot of, kind of small town privacy, confidentiality issues that have been barriers in them expanding practice, not because of stigma as much as anything. So they're interested in scaling up, but then there's another clinic, and I'll refer to it in South Central Los Angeles, that works with very specifically, immigrant population, Asian immigrants, many undocumented, and who seek healthcare, who often sometimes have addiction-related problems. It's an opportunity to intervene. So there's a lot of challenges starting up a practice in that community, in that kind of setting. But startups or scale-ups, this variation of 42 clinics, and that's why you might see the huge error bars with startups being presumably a little bit lower, and then scale-ups probably a little bit higher on the measure. But sometimes you could have a practice seeing a lot of patients, but with respect to these kind of guideline areas, these benchmark areas, they may also be below the average. So I think we're currently taking a look at that, and we see that although being a startup is associated with some of the earlier developments of integration, that it doesn't necessarily guarantee that a more advanced, or we call it mature practice, is still not where they want to be. And actually having this information gives them some ideas about what to do. So it's interesting that, the scores are around 3, as low as 2 when it comes in staff training and development. And this is a score that's reflected by items that have something to do with, awareness of culture and stigma. And we've trained all of our staff, including our front desk staff, our admin staff, our non-X-waiver provider staff, our nursing staff, MAs, et cetera, in kind of the aspects of addiction and its treatment. It also might mean that our behavioral health clinicians have specific training in addiction and MAT, medication approaches to addiction. So as you can see, the average is about 3.13, which is partially integrated, not fully integrated, not integrated, somewhere in the middle, but you can see there's a variation here. So really interesting. the idea here is that these programs are now in their 6th month of a large implementation support project, and I am just getting the second round of data from these 42 clinics. So what happens is that we find that it's often good to match the different strategies that you're trying to leverage things by the different dimensions. So if one of your things is infrastructure, having to do with policy or financing, that would be something that you'd want to target a strategy. If you're finding that on the culture and environment scale or dimension that you're not where you want to be, then obviously you want to try to address that, probably through some kind of workforce training. If it's about patient identification and initiating care, I mean, a lot of clinics start off with, gee, do we have patients who meet criteria for opioid use disorder in our current practice? And some of these patients may be on high doses of medications that you really are a little worried about the dose and have begun a conversation about tapering. Those are very difficult conversations, but maybe that's a place to start. It's also true that there's a strong likelihood that you have patients who are opioid use disorder who you may not know have an opioid use disorder. So sometimes practices institute screening, sometimes practices institute direct patient communications, health communications, or marketing by putting a sign up in the waiting room about addiction, and that people that are struggling can talk with their doctor here about treatment options. So there's a way different clinics have had in approaching that topic, patient identification. There's actually a worry that once you start to do this practice that you'll be overrun with patients, and I've actually never seen that happen. If anything, it's been the opposite, where people start to practice and then say, where are all those patients? But I can tell you that if you do some of those things that I just mentioned, you'll find that the patients will begin to trickle in, but never, they'll never line up, patients out of your panel or practice that are looking for buprenorphine. Typically does not happen. So the point here is that, we often do trainings, we often do workshops, CMEs, coaching, and I think a lot of those opportunities are going to be available to you through the next iteration of this ROPES project. But I think this is just trying to give you an idea as you complete the IMAT, the kind of things that you'll be working on. So here are just some little bit more advanced thinking, and this is using the kind of the lean framework. A lot of the clinics that we're working with are being taught the lean, and some people that have worked in health systems or even during the course of their medical education have learned about lean as part of quality improvement. And so you start out with an aim statement that's measurable. What do you want to do? So by September 2020, we want to include our MAT program to have 3 X-waiver clinicians and 50 patients. So pretty concrete. Where do they get 3 from? I'm not sure. Where do they get 50 from? I'm not sure. So you kind of have to do a little bit of work to come up with a realistic aim statement. It doesn't say 20 waiver clinicians. It doesn't say 1,000 patients. So there's a reason it is what it is. And then some very concrete things. So protocols, processes, coordinated, referral processes, a team. One of the things that's pretty important is a team-based care model, although some of our clinics that are even at the more advanced stage are very physician-driven, where a physician sees the patient, does most of the work. And so what they're trying to do is develop a team-based approach where the roles are defined, kind of the procedures for a visit are set up, so that who does the first contact, what do they do? Can the MA do the urine drug screen? Can the nurse do the vitals? Can the nurse do some of the care coordination if there are other people involved in the patient's care in the clinic with other conditions they have or outside the clinic? Who does behavioral health counseling? If there is behavioral health counseling, can the nurse do that? Do we have a behavioral health clinician? If we do have a behavioral health clinician, what is their goal in the time they spend with the patient? So there's a lot of issues that get worked out as a team begins to come together around patients. And actually, this is really interesting. Some clinics have team-based care approaches for other conditions. Some clinics have no team-based care for any condition. So in some respects, using this kind of team model for addiction is the first foray into managing a patient as part of a team. So, I think the role of the pharmacist could be huge. And actually, there's a pharmacist care delivery model where a pharmacist conducts group visits and really does everything except write the prescription for the medication. So it's really interesting models which are effective and feasible, efficient, and I think the kind of things that are possible based on your clinic. So I wanted to walk through the measure a little bit, and I'll see if I can work my way around this thing. Oh, there it is. I don't want to leave the meeting. I'm going to stop sharing for a moment. Okay. All right. So here's the actual measure. So it's not really that, my dad used to use the word snazzy. It's not that snazzy looking, but I think we can work on that. Some of our more mature measures, if you will, that have been around for years have had professional graphic design attention. This is really just kind of a basic Word document converted to PDF. But you can see that here's the benchmark item, dimension I referenced, and then that goes from 1 into 5. And we're told that, maybe we did need to make it clear that a 2 is somewhere between a 1 and a 3. So these used to be blank, but now they're filled in. So some of these have to do with financing, like 3 out of the 5 have to do with financing. Number 2 has to do with how information goes. So in federally qualified health centers or community health centers, sometimes there's a perceived barrier around patients that have substance use disorder information, and how that information is dealt with. Is that different than HIPAA? And if you are an organization that holds yourself out to be an addiction treatment organization, an exclusive addiction specialty care provider, you are bound by this code, the 42 CFR code, and that is a different kind of more privileged, more confidential way of dealing with patient information. If you're not an addiction specialty care organization, you're governed by the rules of HIPAA. But being able to have worked this out, have some understanding of this, and if you are an addiction specialty organization, or you're accepting patients from an addiction specialty care organization, like a methadone clinic, or like a detox or a residential program, it's good that probably your counsel is aware of what 42 CFR is. It's not complicated, but sometimes it scares people a little bit in terms of what it means. And it's all organized to protect patient confidentiality, particularly around potentially illegal activity, but also some concerns about the reverberations of having a substance use disorder diagnosis. So the first one has a lot to do with kind of leadership. Where is your leadership with this whole thing? And I can tell you that many of the clinics we've worked with have zero CMO support, or CEO support, or board of directors support, but there's a clinical champion who cares about this, who thinks it's the right thing to do, and who's kind of leading the charge. And can Dr. Salbeda do that on his own or her own, or does she really need kind of the CMO to support it? And obviously, it works better if there's alignment of all leadership with the clinical champion, and that happens too. Sometimes there's an interest on the part of the clinical leadership and the C-suite to make this change, but not really translating to the frontline providers. So the frontline providers are a little bit more skeptical. So any of those ruptures at that alignment could lead to some trouble in terms of implementation. So the more of these things that you have at the higher scores, the better you might be able to do, and the better your sustainment might be able to be. Obviously, some of these things, as you're on this call, you might say, well, all that's well and good, Mark, but I can't do anything about any of those. I'm a little bit lower in the organizational food chain. And I say that's all right. I think this is the kind of measure that this set of items has to do with stuff that you as a clinician or clinic practitioner, you might not be able to do, but some of the next ones you will. So here's dimension 2, clinic culture and environment. And again, you've got things about welcome, accept, no evidence for stigma or discrimination, open display and distribution of patient information. So there's a sense that maybe you've made some brochures. I know there's one clinic in Santa Cruz here who's put together some really nice patient educational material, or informational material, I should say, about medications. There's free stuff that you can get from this DHHS, Substance Abuse and Mental Health Services Administration, or the American Psychiatric Association, or the American Society of Addiction Medicine, little pamphlets that are actually very nice. Almost look like they could have been put together by, pharmaceutical or industry. They're that kind of glossy and appealing, and easy to understand, written for everyday patients and families. So the other issue is that, where do we see the patients that are here for addiction medicine? So, one clinic I know felt uncomfortable with patients who suffered addiction coming to the clinic during the usual hours where there could be children, or where there could be other patients who might be, freaked out by the addiction patients. And it turned out the addiction patients were indistinguishable in terms of, hygiene, clothing style, socioeconomics. And I think that was just something that was probably part of culture and just sort of expectation about who people that had addiction were. And I think their first patient was actually a nurse, not from their clinic, but from a different clinic. So I think the idea here is that whatever works, but to the degree to which patients are integrated and care is integrated, like with any other chronic condition, this clinic culture and environment stuff, is less of a concern. I won't go through every item, but I think patient initiation, identification, initiating care. So I'm obviously jumped up to, number 9 and 10 and 11. So let me just say, criteria for offering medications for OUD stands for opioid use disorder in the clinic are clear. So you have some written policies about that. You have patient information sheets and brochures and consent forms. So you want to be able to present the pros and cons of each medication, kind of what we know, what we don't know. They're often, like you would for narcotics, there may be some patient contracts that you use about the medications in terms of, part of taking this medication is being asked to provide a urine drug screen. Part of taking this medication is that we will be checking the prescription drug monitoring program. Pretty sure Idaho has that. To make sure, to know what other medications are being prescribed. So I think being able to have some transparent policies on this, on these topics are critical. And again, if you don't have them, but are seeing patients, this just gives you a sense that, Mark, to be honest, we're at 1, we're not really doing much of anything organized, but now that we have, some ideas, we know what it would take to get to a 3 or even a 5. We're going to work on this in the coming months. So unlike bringing your CMO into the conversation or bringing your Medicaid office into the conversation, or your insurance payers or county leaders into the conversation, these are kind of things that you could work on within the clinic. Care delivery. So this is an interesting benchmark. 6-month retention rates on your patient panel on this medication are tracked to examine your process. So this is really a QI process. So are you tracking retention? And if you are, then that's a good thing. It sort of leads in the direction of having a registry, much like you would for patients who have diabetes, for instance. So these are the kind of things that sometimes a pharmacist, particularly, in our clinics, a population health oriented pharmacist actually keeps these kind of data, kind of keeps a registry. So that's been pretty awesome to watch Jimmy pull those data together and present them. So I think you get the hang that that's really the IMAT. It's possible to take the measure and then transpose the scores onto an Excel, the Excel workbook that we sent along. And I think that kind of plots it. Now, what I can tell you is that, let me see if I can get to it. Okay. So 4 of the clinics sent in Idaho sent in their IMATs, and we were actually able to plot the 4 clinics, different colors here for the clinics. So practice A, these are de-identified. So you might know who you are, you might not. You certainly don't know who anyone else is. So that probably goes without saying. That so there's 4 clinics that turned in information. This red line is the average, and then the red bar is the average, and then the red line is the maximum score. So you can see like this green clinic was towards the maximum score in infrastructure, but dropped on clinic culture, dropped on patient identification, but was still pretty much average. So you could see, okay, well, if red is average, where do we stand? Where does this clinic stand? So the yellow clinic was maybe very honest, right, about the clinic culture and environment. So I think kind of gives you some ideas about the kind of data that you could get, and hopefully as part of a learning. And this is actually interesting, right? Remember, this was the score that was lowest among the 42 clinics in California, equally the lowest among the clinics in Idaho. Just a smaller sample of 4 clinics versus 42, and a little bit of the profile looks surprisingly similar. Here's another way of looking at it. I don't know. I guess it depends on what your fancy is, if you like bar or line graphs. But this, I always like to look at it a few different ways. Sometimes you see things differently. So again, I think the average is this black line going through, and you can see there's some scatter. As a researcher, it's always good to see variation, right? If we think we're seeing variation, we're teasing important variables out, and not much variation here. Maybe even some variation here. So I think these are baselines, right? So this is where your starting point is, and my guess is that it probably would be useful if you want to try to redo this based on this information. That would be great. If not, then these are your scores, and these would be the ones that the team would be Ann and Jen and others would be meeting with you to talk about how to kind of look at this and how to influence your practice. So I think that's a kind of a walkthrough of the IMAT and kind of an overview of the data. I'll just stop sharing the PowerPoint and see if I can see you guys. Most of you are still here. Thanks for staying on. It's a long webinar. Anything over 45 minutes is pretty painful. So thanks for staying with me. Okay, so that's the story. Are there questions or comments or any thoughts about doing this or doing it differently, or kind of? I can tell you one thing. Part of what I'm doing in California is I'm talking with teams using this format. I can't visit them all, but I've been asking them about a lot of implementation support activities. So they have a learning collaborative, sometimes face-to-face. So it meets in Berkeley or LA, and everybody gets money to be able to offset some of the costs. They all have an individual coach, an expert who spends time with them. They have a Project Echo. They have some webinars offered through the California Society for Addiction Medicine, CSAM. I've talked with about 10 teams, and surprisingly, about half of them have said that what was most helpful is having the IMAT to get a really detailed current state assessment, and also to give them like a blueprint for what to work on and what to deliver high quality care. So that was pretty interesting. I have to tell you, when you have those kind of conversations, that was not one that I would have expected. One doc and one of the FQHC says, well, he says that you have to kind of take the long view. He said the short view is it was a real nuisance. It took time. We brought our team together, and that's often costly in terms of everyone's schedule and just taking the hour out. He said, but the long view is it was really, really helpful for us. So it's a short view, long view thing from I'll just say Dr. Murphy's perspective. So I think that's the story. I don't know where you guys are with approaching it, but hopefully I haven't talked you out of it this morning.
No, not at all. I just wanted to thank you again. I think our clinic kind of shared a similar experience that you had as well. Thought we were doing fairly well with it, and once we started going through the IMAT, realized we had lots of room to grow. And it was just a really good, helpful tool for us to use as we kind of go forward and identify the areas that are in need of strengthening. So I appreciate it.
That's awesome. Well, I think in looking at the data that we did have from your clinics, that you're all pretty much at the startup phase, so you're all in it together. So hopefully there'll be that, I don't know, peer recovery support that comes along with not doing it alone, and really realizing that other people are encountering the same issues that you are in terms of your culture, your workflow, variation in provider receptivity and sense of confidence in doing the work. Challenges with patients. I don't know how different your patients are from one county or one location to the next. That might be interesting to look at. People are definitely identifying cultural aspects, whether it's Asian or Latino, that are more reluctant to seek help, take medication. So some practices that work with non-white patient populations are noticing growth being a little slower in compliance or adherence, retention being a little harder. So we don't know a lot about that from a health services perspective, health services research perspective, but we've definitely been hearing about it from people on the front lines. There's not a lot of data on that either, so I think be interesting. In American Indian populations, we know even less about. So we know that there's a lot of opioid overdose, but we don't, and alcohol and suicide, but we don't know about differential treatment response and adherence and so forth. The good news is there's a huge role for everyone. I mean, it's a kind of a condition that it does require a team. No one should go in there alone, so to speak. So the role of the behavioral health clinician is key. The role of the pharmacist or nurse is key. The role of the MA is key. The role of the prescriber, physician, nurse practitioner, et cetera, is key. So it's really awesome when the team comes together. Makes the work sustainable too. Any other questions, comments? Might be giving everybody back a half hour, Rachel, which is bonus time from where I come from.
Absolutely, especially on a Monday, right?
Yeah.
Oh, I just want to say thank you again. I think that, again, as our group, as our consortium starts to look at ways that we can work together, the IMAT is going to be really, really useful for us. I think looking forward, we're going to look to see how we can identify some of those areas of strength in each practice and kind of cultivate some leadership and peer-to-peer education around those areas. And so I think moving forward, we really want to look at this as a tool for individual clinics, but also think about it within the context of us working together as a team to develop in each of those domains. So thank you for your expertise in developing the tool, and then also your time today. I think that that gives us a lot of context, and certainly we'll put the invitation out there if anyone wants to repeat the IMAT. If you weren't the one that completed it for your organization, we can go through it with you again. So please do let me know if you have questions or follow-ups on that. And we will be asking everyone to repeat it at least once more at the end of the planning period, just so we can kind of see how some of those development activities have hopefully move the needle a little bit. So again, thank you so much, Dr. McGovern, for your time. We absolutely appreciate it. Reminder that we'll have this meeting recorded, so if you do have colleagues that you want to share this with, we'll be able to do that. And I think, again, with that, we can just close for the day. But thank you again for your time. Thank you to everyone for joining us, and we will chat with you all soon.
Thank you, Dr.
Hey,
McGovern.
Rachel. Thanks, everyone. Have a good week.
Have a
Happy
good
holidays.
Thank you.
Thank you.
Bye-bye.
Bye.